The webinar is organized today in response to requests from the CIS countries to the P4H network, because there is a need to create a special platform to discuss health financing reforms implemented in the CIC. It was suggested that participating members could discuss the achievements progress that was made since national independence in 1991. We are extremely happy that not only experts in health financing are present, members of government, representatives of the ministries of health take part in the webinar. For instance, Deputy Director General of Health Institute, Dr. Ajarov, also participates today, along with others. Also, representatives of health ministries take part. Some do not take part in this webinar as speakers. For instance, former health minister of Uzbekistan, Mr. Kayumovich, as well as Mr. Bertanov, former health minister of Kazakhstan, also participate in this webinar. So it is extremely important to note that people who introduced the necessary reforms take part in this event. So we could say that the legacy of health systems in the CIS countries is rooted in a common centrally planned and socially oriented health systems. However, since the early years of independence, the promise of universal coverage has come at the expense of equality and equity with limited resources. And it became difficult for the CIS countries in the early years of independence to meet the growing demand for health services through budget funding alone. Therefore, during the reform process, different approaches were used, among others, compulsory social health insurance, which has been widely supported at the political level in these countries. Social health insurance has been introduced in Azerbaijan, Kazakhstan, Kyrgyzstan, countries participating in our webinar today, as well as in Russia, Tajikistan, and Uzbekistan. Although the countries have taken different approaches to introducing health insurance, there have been some common feature in their reforms, and we'll discuss them today. I will also discuss how well or not so well a country's financing reform worked during the COVID pandemic. So if you don't have any particular urgent questions for me, let's proceed with our program. So I give the floor now to Mr. Claude Meyer, coordinator and head of Secretariat of the P4H network. Mr. Meyer holds a Master in International Relations and Economics. After implementing international non-governmental health funding projects in Africa, Claude has also worked in the East, in Yemen, and he collaborated with the European Union and in Philippines. Since 2011, Claude has headed the Secretariat of the P4H network that organizes these events today and works from the WHO headquarters. Also, P4H was launched in 2007 during the G8 summit in Germany. Their 8 leaders agreed to actively promote social standards and to strengthen health systems. P4H operates in more than 40 countries in Asia, Europe, America, Africa, and in 2021, the network began working actively with the CIS countries to increase knowledge and share lessons. So, Claude, please, the floor is yours.
Thank you very much, Aino, for your kind words. Good afternoon, good evening to all the participants. Please apologies for not speaking in Russian. This is a language that I unfortunately don't master. And I would like to say just a few words on 4 different points. The first one is I have some echo. I don't know if this can be solved. I would like to answer the first question of why the P4H network has been created. In the world, we have every year 100 million people that are driven into poverty because of direct health expenses. As we know, in the Sustainable Development Goals, we have a universal health coverage as a target. And in this target, we have both the dimension of quality of health services and protection against financial risk. There are many stakeholders and many experts around the world that are trying to lower the out-of-pocket health expenses that is the financial risk manifestation. So P4H for this is a global network of institutions and of expert specialists that are committed to this effort of lowering the out-of-pocket health expenses. We try to support countries and regions to make policy changes in favor of equitable social health protection and health financing, and this contributing, of course, to universal health coverage. Second point is who are we? The network, the global international network, is comprised of 19, at the moment, 19 national and multilateral institutions that offer expertise, financial support, and most importantly, political will to advance social health protection and health financing for UHC. All the members, the 19, all endorse the P4H values, the sovereignty of the countries, the diversity, the transparency of information and accountability. And of course, knowledge exchange. Members can also include, okay, we have, of course, the government institutions, and we have as well academic institutions, we have international and regional organizations, we have development banks, and we intend as well to include private organization and civil society organization. This is not yet done. The whole network is also comprised of a coordination team with a coordination desk that is at the moment located in WHO HQ and ILO HQ in Geneva. Supposed to be World Bank as well, but the position is vacant. We have what we call country and regional focal persons that are nationally based, recognized experts and facilitators in health financing reforms and social health protection. And we, as a third point, we have a certain number of services and products that we offer to our partners. And I already mentioned those P4H country focal persons that are mobilizing a broad range of stakeholders at national level to engage into those reform processes. The 3 other ones that I would like to mention is that we inform, educate, and connect the global community of health financing specialists, mainly through some knowledge management tools like the P4H digital platform. And I encourage everybody to register in this platform to access all the different information and features that are available. The third one is that we build capacity, especially through our flagship program that is called the Leadership for UHC program, that is targeting high-level decision makers to basically overcome the non-technical dimension of reform processes in social health protection and health financing. And we also offer analytical tools such as the political economy tool and others that we're preparing. So this is in a nutshell the P4H network. The last point I wanted to make is that Why do we organize this series targeting the CIS countries and the post-Soviet countries? We believe that many reforms have been going on and are going on in the recent years, and that this is an area of the world, a regional part of the world that has not been really sufficiently taken into account in the recent years. And we believe that in our knowledge exchange function, this region is very important to be included in webinars organized by the P4H network. So this is the main reason we have launched this series, and it is with great pleasure that I'm introducing the series today. Many thanks to everybody for listening.
Thank you very much, Claude. Спасибо, Claude.
Thank you very much, Claude. It was very nice to hear your opinion. I would like to note also that we would like to welcome Mr. Chemboleng Zhikzhik the member of the Mongolian parliament. So the diversity is wide when it comes to geographical representation. So now I'd like to give the floor to Madam Kulaeva, Director of the Technical Support Team for Decent Work at the ILO in Moscow. Olga Kulaeva graduated from the Faculty of Economics of Moscow State University and has a PhD in economics. She conducted research on labor market and professional training. Different years she worked at the People's Friendship University in Moscow and worked as project director for the Swedish National Council on the labor market and Swedish Public Employment Service. Since 2016, Madam Kulaeva has been appointed as a director of the ILO Office for Eastern Europe and Central Asia. Please. Thank you very much, Ainur. I would like to welcome everyone on behalf of the ILO and ILO Office for Eastern Europe and Central Asia. As was said by Ainur, reforms of social health protection have been launched since the independence of the countries in the region. We also remember very well that the social protection, health protection system that existed in the USSR was quite comprehensive, but it didn't respond to the new realities any longer. So the reform processes also covered healthcare systems. They faced new challenges and countries tried to find solutions to these challenges. The ILO always welcomes the work to exchange views and opinions between member states. So it's extremely interesting for us and for our member states to learn what's been done in other places, what could be done, what lessons can be learned. So we always welcome similar events, and I would like to welcome everyone who takes part in this event. And the P4H platform is a very important network. The ILO considers the right to social protection as a fundamental human right. So all together, we should try to do our utmost to realize this right. So globally, we see that it's not the case, unfortunately, because globally, around 47% of global population have access to at least one benefit of social protection system. It means that around half of the world's population simply do not have access to more benefits. In Europe, the percentage is higher, it's 85%, but still there is a lot that needs to be done. When it comes to healthcare systems, so we see that here we talk about 2/3 of population, of the global population. So for our sub-region and for the ILO, the social health protection is a very important part of our work. So I'd like to thank my colleagues in Geneva for organizing this event. So a global crisis, a global financial crisis, COVID-19 showed us who is the most vulnerable and what needs to be done to overcome all gaps and barriers. So when it comes to our work, we accompanied countries in the work aimed at implementing and developing national social health protection plans, as well as other work aimed to integrate social health protection services and labor. So today we'll discuss this experience. Azerbaijan, Kazakhstan, Kyrgyzstan, all of these countries have their health insurance systems, social health protection systems. So we'd like to underscore this, that this principle responds to our recommendation 202. Today, our member states will share their experience. And as I said, compulsory registration, compulsory health protection made it possible to enhance their health coverage. But still, a lot needs to be done to ensure access to quality healthcare. And we know that thanks to the transition to the market economy, many faced the fact that services were not free of charge any longer. So financial component is quite important as well. Therefore, it would be quite important to hear the experience of all of the countries. Our organization values a lot the culture of dialogue. It is a fundamental principle of our work. And today, we urge everyone to discuss all of the issues openly so that we can make the necessary conclusions. We support the organization of this event. We believe that social health protection and social protection overall are quite important interlinked elements. We would like to wish you every success, and we think that this experience will be very enriching. Thank you very much, Olga. I'm eager to introduce you our special guest, a well-known speaker and expert in health financing circles. So, Ms. Lou Tessier, health protection specialist at the Department of Health Protection at ILO. She holds a master's in business administration as well as master's in development economics and international law. Lou has 10 years of experience in international cooperation, including in Africa and Asia. She has worked in the areas aimed to reduce poverty through access to healthcare, social protection, and decent work. Lou has also worked for World Bank and other international organizations. Lou, please, the floor is yours.
Can you hear us? The floor is yours. Thank you so much. I will share my screen. I have a PowerPoint. Yes, here we go. Thank you very much. Well, first of all, let me thank you, the P4H network, Anour, and also all of the coordination desk based in Geneva for organizing this webinar and for having such a much appreciated convening role today. So I'll give just a quick introduction. Yes. Oh, sorry. All right. So I'll give a quick introduction to the panel discussion. As was underlined by Olga, of course, from the International Labour Organization, we come very much with the social protection angle into this discussion. So I'll try to clarify some of the concepts around the standards of social health protection and how they contribute to the broader goal of universal health coverage, or at least we hope they do. And we'll go over a few concepts on coverage and adequacy of benefits that hopefully transition to the very rich discussion we're going to have with the panelists today on trends specifically in CIS countries. So social health protection designates a series of public and publicly organized measures to achieve effective access to healthcare without hardship and to income security to compensate for lost earnings in case of incapacity to work linked with a health condition, could be sickness, could also be maternity, for example. Very much where the concept of social health protection comes from is the human rights instruments and the international social security instruments that have come to complement human rights instruments and to provide guidance on how to build national systems to substantiate those rights. Here I have listed a number of such standards. One flagship standard is the Social Security Convention of 1952, because this is the only instrument that actually provides guidance across not only social health protection, but the overall social protection system. And it's been ratified by over 60 member states. And it's been used as a benchmark for the development of systems in a number of countries. What's important to know about those instruments is that they all set minimum standards that need to be respected when it comes to entitlement to social health protection. And in this respect, all of them set targets to limit the out-of-pocket payments that households may have to incur for healthcare. So this is very much kind of the angle where the social health protection approach comes from. The standards, they're rights-based and they're outcome-oriented. So they propose an approach by which we're not telling member states exactly how to provide social health protection, but rather providing a series of principles that need to be respected by the systems that are being put in place. And those relate directly to the framework of the human rights to health and social security. So, I'm not going to go over all of them, but at the core of those basic principles are the ones of the overall and primary responsibility of the state to provide adequate and predictable benefits over time, and to do it in a way that secures broad risk pooling and solidarity in financing. Overall, the spirit of the social health protection instruments is that, of course, the role is to facilitate access to healthcare, but that there needs to be an important redistribution component and progressivity in financing within the way that systems are built. And if we move towards coverage and adequacy of benefits, one thing that has come out of the latest edition of the World Social Protection Report is that almost 2/3 of the global population is protected by a social health protection scheme. Now, those include contributory schemes such as social health insurance, but also non-contributory schemes and systems such as the NHS in England, for example. There are pronounced regional coverage gaps, and populations in lower and lower middle and low income countries are largely left unprotected. What we're seeing is that now, you know, the higher middle income countries have coverage rates that are very high, almost as high or higher than high income countries. But there is really a huge gap now between higher middle income countries and lower middle income countries, where, you know, lower middle income countries and low income countries are around a fourth of the population covered, not even more. And what we're also seeing is that even though some countries, especially upper middle income countries and high income countries, have achieved, you know, over 90% coverage, barriers to accessing quality healthcare remain. You know, with high out-of-pocket payments, physical distance, and issues with availability and acceptability of health services. So what that does tell us is that indeed, you know, it points to difficulties in ensuring the adequacy of the entitlements that to social health protection that are in the law. If we look at indicators 381 and 382 of the SDG framework on universal health coverage, we see here that the data computed by the WHO is also pointing very clearly at differences and gaps across country and income level, but also to the fact that there remains important barriers of access because the services are not there, or because they remain unaffordable for at least some groups of the population. So if we look now at recent trends in social health protection in CIS countries, what we see is that there have been some important health sector investments prior to the rollout of national health insurance systems for the extension of coverage. And there is much to be learned on this, because it's not under any kind of condition that you can successfully roll out a social health insurance model and scheme. We also see that there is a mandatory nature of national health insurance and legal entitlements. So in this sense, this is of particular interest, and as the ILO, of course, being a standard-based organization, we welcome the fact that entitlements are entering in the law. Would absolutely encourage those countries to apply for ratification, because this is one of the ways that member states do show their commitment to a sustained social health protection system. We also see that there is the establishment of national health insurance institutions that act as single payers, pooling a mix of financial sources, social contributions, and government transfers from taxes. So those trends are particularly interesting to discuss. I think that there could be lesson learned, of course, within the region, but also much more broadly for the rest of the world, especially for middle-income countries in Asia and Latin America. What we see is that there are also common challenges. One is the extension of coverage to households in the informal economy. And as we know, this is part of a broader issues of countries' efforts towards formalization and the hurdles that one may encounter in the way. There is the question of sustainable financial management and how to ensure long-term sustainability among and among other things, an aging population. And then there is the digital journey and information systems that need to follow the core principles of respect of privacy and of social health insurance institutions. And then there is, of course, the issues around purchasing services and the relationship with providers. I think that I'm going to stop here. I look very much forward to hear our three speakers today and actually to learn from the experience of those countries. I would like to thank you for your attention and to thank again the network for organizing this exchange. Over to you, Anu.
Thank you so much. Thank you so much, Mrs. Tessier. It was exceptionally interesting. You're an expert, a world-renowned expert. Now, this is the most interesting part, the experience shared by the CIS countries. We have three panelists in alphabetic order. I would like to give the floor to Nigar Bayramova. Nigar Yusifovna happens to be the deputy chair of the board of the Public Agency on Compulsory Medical Insurance of Azerbaijan. She has a master's in biology and finance and credit. Since 2016, by the decree of the president of Azerbaijan, she was appointed to the position of the deputy head of the government agency on compulsory health insurance. Nigar Hanum, you have the floor. Thank you so much, Aynur. I'm so happy to welcome everyone, all of the heads and organizers and hosts of this webinar of the P4H network. I would like to welcome the ILO, the WHO. I would like to welcome today's speakers, and I would like to welcome all of the participants of today's webinar. I would like to share the experience gained by our country in implementing the compulsory health insurance schematics. First and foremost, I would like to tell you that we are implementing many reforms in the area of economy, social reforms, and of course, we are transforming the public health care. We are carrying out the public health care reforms, and the main impetus of these public health reforms is the insurance, and the president of Azerbaijan is keeping an eye on the reforms. It facilitates the access of our population to healthcare services. I would like to project the slides of my presentation. First and foremost, I would like to present to you the participants of this webinar. I would like to introduce certain indicators of our healthcare system. Our population is about 10 million people. The average life expectancy is 73 years of age, and we have about 31.8 doctors, general physicians per 10,000 residents, 55 nurses, and 65 doctors and 42 nurses in the capital of our country, Baku. We have 518 hospitals. The number of beds per 10,000 people is about 45. 44% of beds of the country is concentrated in the capital of Azerbaijan, in Baku. We have expenses, and those expenses per capita were 167 manat in 2020. Compared to previous years, we have increased expenditures by two times. The expenditures for healthcare in 2022 was about 1,789 million manat, which is in US dollar equivalent, 693 million US dollars. This is 6% of all expenditures of the public healthcare budget. And in the history of our country, this represents the highest share of expenditures for public health care. And in percentage, it's about 2.3% from the gross national product. How did we introduce the mandatory compulsory health insurance? Our state agency of compulsory health insurance was founded in November 2016. In 2016, certain amendments were put in the law on health insurance, which was initially adopted in 1999. We have introduced we have started our operations by analyzing the experience gained by high-income countries. First and foremost, we tried to analyze the European experience, Russian experience, French experience. We have paid a visit to Estonia, Turkey, South Korea. We have studied the experience of those countries. While analyzing this experience, we have embarked upon a pilot project starting in 2017 within the European policy of cooperation with the European Union. We have organized a training which lasted for 2 years, and within the 2 years, all of the experts from different European countries took part. They were invited guests. They paid a visit to our country, and they have extended support to our public agency, and they have conducted consultations as well as participated in the training. And on the basis of these consultations, we were able to form our system of premium tariffs, rates for services. We have conducted different projects within this program. Since 2017, we have implemented a pilot project in 2 regions of our country. Since 2018, we have added a 3rd district. The total number of residents which was insured was 3% during the duration of the pilot project. 3% of our population was fully insured. During the pilot project, our residents were not paying insurance contributions, but they were getting healthcare services. And we have reached good indicators. We use the beds of the hospitals. While we raised the use of the beds from 45 to 65, the average number of days in hospitals has gone down from 9.6 days to 4.9 days. Those are good indicators to be proud of. And the survey that was conducted after the pilot project has demonstrated a high level of satisfaction from the residents. The overall insurance package in the pilot was has covered different types of services, 1,829 medical services. The pilot project was conducted between 2017 and 2019. In 2020, we started an incremental implementation of the compulsory health insurance to cover the whole area of Azerbaijan. First, we have made a decision to start the implementation of the compulsory health insurance from certain areas. We have separated our area into north, south, west, east, and we were every quarter of 2020, we started introducing the insurance scheme to cover 1/4 of the area of the country. But our plans were adjusted. We were able to implement in January 2020 only 1/4 of the insurance scheme, 2.5 million, 25% of our population was fully covered. Then the pandemic broke out, and as you know, the project was stalled, and the compulsory medical insurance project was stalled. We up to 2021, it was extended. As for the full implementation of the compulsory medical insurance to cover the whole area of the country, it happened in April 2021. We can state that it took 1 year. We have covered the whole area of Azerbaijan by a mandatory compulsory health insurance scheme. Now, we are implementing and covering all residents, all citizens of the country are covered by the compulsory health insurance. All of the population is covered by the compulsory health insurance. Foreigners are covered. Stateless persons are covered by the compulsory health insurance, as well as those UN persons enjoy the protection in Azerbaijan. The refugees are covered by the compulsory health insurance. Foreigners who have and employment contract are covered by the health insurance schematics as well. And we have started the preparation to the implementation of the compulsory health insurance. First, we have designed and developed the rules and standards. We have changed our legislative base. We have amended the laws. Then we have founded an organization on management of different medical healthcare facilities. It was named Tabib, and all of the health facilities are subordinate and under the umbrella and auspices of Tabib. We have also conducted and carried out structural reforms of healthcare facilities. Each healthcare facility has put together an insurance units. Those insurance units were responsible for applying the compulsory health insurance schemes. Certain health facilities were merged. Smaller healthcare facilities merged into bigger health facilities. And in order for us to manage them better and easier and smoothly, we have put together information, communication technologies, infrastructure in health facilities. However, the infrastructure level leaves a lot to be desired. It was very low. We can say that there were a couple of laptops in each hospitals, in the statistical department, in the accounting department, but when the compulsory health insurance scheme was implemented, we have submitted and supplied computers and laptops to all of the units in order for all of the accounting to be conducted online on the digital basis. We have trained the healthcare facilities and the employees to be able to apply the information communication technology to know how to use laptops. We have also raised the awareness of the population I would also like to zero in on the public financing of compulsory health insurance, how our fund is financed. The government allocates finances. So besides the healthcare contributions, it is funded by government programs such as TB, hemophilia, mother and child healthcare. The overall envelope is 143 million manat, 84 million US dollars is allocated, and 977 million manat, or 575 million, is made up from insurance contributions for the population. Our government pays per each resident. We have such a system that even if the residents are working or non-working, the government covers the insurance. 90 manat per year is the standard, and this amount is upgraded, taking into account the inflation rate. It's adjusted upwards. Besides the government paying for each citizen and resident of the country, we are levying certainly the employer. The employers pay 2% from the salary, and the employees pay 2%. When this amount is exceeded, then it goes down to 0.5%. As for self-employed people, they pay 4% from the minimum salary. In our country, the minimum salary is 300 manat. 4% of the 300 manat is 12 manat, which is in the equivalent, in US dollar equivalents, $7 US. Self-employed people pay the equivalent of $7 US. People who are not filing a tax return and do not report that they're gaining income, and those persons who are not active economically, retired people, children, handicapped people, and pregnant women up to 2024 are exempt from paying insurance payments, insurance contributions. Right now, they are not obligated to put in any payments. We have additional financing sources to fund the compulsory health insurance. I don't want to enumerate all of those contributions, but I can tell you that this is excise tax from gas, alcohol, tobacco products, and they are levied not by our agencies, but those excise taxes are levied by the General Tax Directorate under the auspices of the Ministry of Economy of Azerbaijan. And those funds that were levied are transferred to our accounts, to the fund of the compulsory medical insurance. If you compare the share of financing from the government side and other additional side, you can draw a conclusion that in 2022, 56% of the insurance contributions was funded by the government budget. Those are the insurance contributions that the government is paying for each resident. That is 90 manat. 37% of insurance is paid for by the employer and by the employee himself or herself. 6% is paid for by the excise tax on alcohol, tobacco products, and 1% is levied by through the self-employment tax. It's a self-employment tax of 1%. Now, our insurance package of the compulsory healthcare insurance is made up of the following. Right now, our overall benefit package covers 2,025 medical services, 2,550 medical services, primary healthcare, emergency healthcare, outpatient healthcare, therapeutic healthcare, laboratory services, therapeutic services, physiotherapy, free medicines if you are in the hospital, free emergency, free outpatient provision of medicine, as well as if you call an ambulance, you don't pay for it. The overall insurance package as of now, since it's the first year of the implementation of the benefit package, what it doesn't cover, it does not cover healthcare services which are rendered to treat tuberculosis, cancer, diabetes, that the government provides for, because the government has set up dedicated programs. Transplantation is not covered, plastic surgery is not covered, artificial insemination and dental care is not covered. We have prepared a new benefit package, and transplantation has become part of this benefit package. We have also included certain medicines for outpatient patients, for certain diseases, but not for all. And we have supplemented a high share of hospital services. Right now, this benefit has not been approved yet, but we hope that it will be approved in the near future. We have also facilitated access to healthcare services for our residents, especially those very prohibitively expensive services would be provided with greater ease, and we have removed barriers. What are the challenges that we have encountered when we were implementing this healthcare system? Our healthcare system was totally unprepared for this large-scale reforms, the level of IT knowledge, the number of laptops, the lack of uniformity of healthcare personnel. 65% of doctors work in the capital, and high expectations of doctors and nurses as far as remuneration goes. They expect a very high salary. Before the introduction of the compulsory healthcare insurance, doctors and nurses provided services, but they expected an out-of-pocket payment from the patients, and they were felt obligated. And so doctors were expecting that their remuneration would be elevated. They had very high expectations. From time to time, our residents, our citizens, do not trust the doctors, do not trust the medical personnel. Also, we have a high share of residents who work in informal economy. If you look at the physically active share of our population, 50% of our population, 5 million residents, out of 5 million residents, officially only 1.7 million people are working and have a gainful employment. The rest of the population are employed in informal economy. And this is a high share of informally employed people had a bad impact on the implementation of the compulsory health insurance. We made a decision not to levy the insurance contributions from the share of the population up to 2024 who are employed in informal economy, at least at the initial stage of the implementation of the compulsory health insurance, so that the population would gain access to healthcare services, so that the population would start using the healthcare system. And later on, as the system would be implemented, we would start levying the insurance fees from the informally gained population. We have encountered problems with the pandemic, with the COVID-19 pandemic, and all of the countries have experienced difficulties due to the COVID-19 pandemic. What have we achieved? We have strengthened the legislative base in the area of compulsory health insurance and public health care. We have carried out structural reforms in state medical healthcare facilities. We have centralized the management and the purchasing agreements in healthcare facilities. We have conducted this process. It's an ongoing process. First and foremost, I didn't tell you about the salary rate of healthcare personnel. So if you're looking at doctors and nurses employed by the hospitals, we are using different payment methods, fee for services and bank transfer methods or some other method. And now all of the hospitals, if before the implementation of this compulsory health insurance before 2021, they were funded by the state budget, and the government has allocated expenditures to fund the hospitals. Now the compulsory health insurance funds them depending on the healthcare services that they have rendered, depends on the rate schedule. We have removed the franchise that the population has to pay, that the patients have to pay for services. This is a markup. If a patient gets medical services, our law had a certain markup or a certain franchise. If a patient does not use the primary health care, then in order for him to get service, he seeks medical assistance, help from a specialist, and that was removed until 2023. It will be reinstituted in 2023. Our residents gained access to private clinics, private facilities, but with certain limitations. First and foremost, the resident must go to a government state hospital. State-run hospitals may provide the service or may not provide the service. If they do not provide the service, they refer the patient to a private healthcare facility. And the state-of-the-art surgical operations are carried out in private healthcare facilities. We're talking about cardiovascular surgeries. We're talking about high-tech surgical interventions to treat cardiovascular conditions, prosthesis, as well as different high-tech medical interventions are carried out in public healthcare facilities. We are using certain programs which are implemented up to now. Right now, we are launching a new program to attract doctors and nurses, Azerbaijan residents who have been trained abroad. And we are trying to hire them back in order for us to start providing healthcare services to the residents of our country. Thank you so much for your kind attention. Thank you so much, Mrs. Bayramova. It was very interesting to hear your experience. We will give the floor to the next two speakers, and then you will be able to answer the questions that were addressed to you. Maksut Karimovich Kulzhanov, the chair of the board of the Fund of the Compulsory Health Insurance of the Republic of Kazakhstan. Maksut Karimovich is the founder of multiple institutional changes in the public healthcare system of Kazakhstan. He is a doctor by training. He has graduated from Karaganda Medical Institute. He is a doctor and PhD of medical sciences. He is a professor, and he was a deputy minister of healthcare of Kazakhstan, the general director of the Republican Center for the Public Healthcare Development of the Department of healthcare. He has founded the Kazakhstan Higher School on Public Healthcare, and he was the dean, Maksud Karimovich. You have the floor.
Distinguished participants, thank you very much for your kind attention. I would like to present a few details when it comes to reforms. Our healthcare system had declared public guarantees for the population. Our state hasn't been able to realize fully its.
In 1996, we move on to the next stage. So there were additional mechanisms that we're able to take on board. But unfortunately, the local systems and the employers were not ready for this. So we had to go back to the budgetary system. But the function of financing was responsible for the local authorities. The next slide, please. Moving on to 1999 to 2004, this was the decentralization of the budget. This is the first stage in the introduction of the new systems, and the state actively took on board market mechanisms. And there was obviously more competition for purchasing and whatnot. And also the computerization of the entire system was introduced. And this was a stimulus for various components of the system. These measures were able to increase the effectiveness of the overall system and improve healthcare, and allowed us to expand the system. Laws were introduced, and with the framework of pilot projects and experiments, we were able to successfully roll out this system. To introduce the OMS in the 2000s, it was a high percentage of the GDP. It was about $5 million US. Currently, that was about 3% of the GDP. That was about $7 billion. Understand that most of the countries of the CIS were not able to do this. But overall, the main reasons most of the financing went to young people, older people, people that are of pension age, and so forth. Of course, new technologies and new ways of caring for people. The cost of these things bit into the budget. Next slide that I want to show you. This shows the introduction of the system, the financing that we used. And if you in 2020, more than three regions were covered by the system. And I think we increased funding for outpatient clinics, for consultations, and for high-tech medical care. This volume of financing allowed us to provide care at a high level. The next slide shows the current finance, or the model of financing. This is about 97% of the financing for medical services increased. And you see the group of people that are covered: old people, pensioners, students, and others. 6% of these spending goes to other institutions. The structure of the spending for ministries shows the remainder. The funding goes for education to various ministries and so forth. Next slide, please. The coverage of the population by the USMS systems, it's 81% of the population, or most of these are people of working age. And we're covering more than 3 regions of Kazakhstan. So the fund is actively reporting. And the insurance system is working. The next slide, please. This shows medical services throughout the country. Using this fund and the implementation of this fund. There are several thousand, 1,300 people implementing. 52% is coming from the private sector and the rest from the government for the most part. And it covers state organizations and private organizations. A great portion are spent in various areas, from dialysis for outpatient services, for oncology and others. And obviously these services provided by state medical services. In 2021, to improve the effectiveness of the system, we introduced new phases, which included testing in outpatient clinics and physical therapy and other things. Next slide, please. We are going to improve the financing for priority areas within the framework of this. We will improve the purchasing system as well and the payout system. This obviously will take into account the change in salary levels. And within the framework of the purchasing system and payout system, we are trying to automate the system or computerize the system so that it makes it more easy. This is underway. This is based on a federal system and it's managed by the Ministry of Financing. And hopefully this new system will be able to also address more crisis systems. Protection of the rights of patients. Medical systems with the SMS should allow us to better protect the rights of patients, to improve mechanisms for feedback with the population, to increase the effectiveness of thanks to a contract center. Obviously, we're having new systems will be introduced to improve information. We want to improve the effectiveness via contact center, improve the qualification of the hotlines and the people manning them through training. We want to reduce the time, the wait times for patients calling in. Thank you. Many thanks, Maxim Makarievich. Apologizing, but I think that there were some problems with these slides. I heard the feedback and either were not able to provide them in a timely manner, but I think that is something that we can fix. Oh, yeah, the slides were out on the site, says the speaker. But obviously, if there are any questions from the participants, I am ready, obviously, to take those questions. Anyway, the idea is that we are doing everything possible, and there's work underway to improve the system in everywhere possible. We're going to take into account all of the requirements that come up in the organization and the development of a system of medical assistance. Some of the key elements here is obviously we want to achieve good results. Thank you, Maxim Kirillovich. My apologies there. I'm sorry that there were some problems with these slides. Well, that was my fault. But we heard all of the presentation in Russian, and you can see all these slides on our site. And I will send you the link in the chat box. And you can always read them in Russian, and I think there's a translation into English as well. Now we'll move on to the experience of the Kyrgyz Republic, Madam Azerbayev, who's head of the fund for insurance in the Kyrgyz Republic. Our speaker has a high medical training, and she was also worked in the World Bank on state financing and the introduction of pay systems. Various years she worked as specialized on financing within the Department of Health of Kyrgyzstan in Bishkek, and also on the rights of women. So we're very interested in hearing what you have to say, madam. Good morning, colleagues. I'm very pleased to welcome you on behalf of the Kyrgyz Republic. Can you hear me? Yes, we can see you and we can see the slides as well. I had a problem with the last speaker, perhaps. For the time being, we can see it very well. There's no problem. We don't see it on full screen. It's just a small version. Okay, we'll work with that. That's fine. As you're well aware, we all started pretty much the same way after the breakup of the Soviet Union. We tried to get by despite the difficult economic situation. We introduced obligatory medical health. This included an insurance system to get through this difficult period. In Kyrgyzstan, this started in 1999, but it really, in the 1990s, but it really didn't get full into full string until about 1996. In 1998, there was the first law on medical insurance. And from that point, we introduced medical insurance and throughout the country. Our country is not too big. At that particular time, we were about 5 million. So it wasn't too difficult for us to roll out the entire program throughout all the regions of the country. So we started providing the first services, health service, and we introduced the first mechanisms for payouts based on the state budget was still involved as before. The biggest part of the reform process in Kazakhstan took place in the next decade, 2009 to 2020. And that's when we created a single payer system. In every oblast of the country had its own budget, its own financing schemes. During these 10 years, we had to raise this to the federal level. So during that time, all of the funds were transferred, all state funds were transferred. During this time, we understood that the health system could not work under the old Soviet system. We couldn't provide free medical service to all our citizens. So the state guarantees were not there. We had to determine the rights of individuals for different levels of medical service. This included all sorts of services, including outpatient services. So obviously we worked with the health ministry and other health organizations and institutes. We introduced a quality control system. In 2001, when we realized that the provision of medicines was also difficult, we put in place a system of advantages or privileges for certain individuals. So people were able to buy their medicines that were under prescription, but with some discounts. Work was undertaken so that state funds from the budget could be sent out to various structures, including outpatient clinics and whatnot. Then we realized that various services would be paid for in different manners. We set up some norms for payout for clinics. So these were the main things we did over a period of 10 years. So it was had to do always with the insurance coverage and the funding for this. And the last 10 years really were concentrated on the system itself. And we've had some very good results. Until 2008, we provided funds to all of the regions. These were mayor's office, municipalities, and so forth. And only in 2016, there was an agreement according to which that the historical budget was also be transferred to the OMS fund. This allowed us to level out the playing field in terms of financing and assignation of funds for healthcare throughout the country. So in various regions, you find that they have pretty much the same level of service. Now, concentrating these funds allowed us to create one channel for financing. This is the health ministry that would be responsible for this, and they are now. So we finance these on the basis of results of their work. And so we put out the funds, and then the various health institutions then manage these funds, these sums, and we control them. Obviously, funds go for paying the medical staff, for purchasing medicines, for various other services, you know, the various spending that occurs for healthcare, for patients. Over 20 years, we continue to assign fines, but we realized that after a certain period of time, some of the actors stopped reacting to our fines. And we noted that it really didn't have any impact on the actors in the health system. So how were we able to improve the healthcare in Kazakhstan? Well, we actually had a pretty good system, but we had very low quality in certain areas. But unfortunately, the fines were no longer able to stimulate the actors in the system. So we adopted another method. So we tried to do work on a positive way rather than a negative way. We tried to introduce a system of pluses and financial stimulus for good results in the health sector. When we're talking about good healthcare, we can't look at just one aspect of the healthcare system. You have to look at it as a whole. And so we also had some problem with various statistics and medical expertise on what was going on. What was happening in outpatients, what was happening with the provision of medicines. At the same time, yes, at the outset, we had good results. When we put in place the project of the World Bank, and there was a lot of money provided to us, we noticed that all of the various institutional players were interested. They were very pleased and really willing to improve the quality of their work. Unfortunately, the payout to this kind of state did not occur. And so what happens when the project was over, rolling out to the national level, this kind of payouts was not possible. And so we had to back up a little bit. And if before it was 15% of the budget, then right now it's about 5%. And now it's gone down to 3% of the budget, of the official budget. And so health organizations have become a little bit less interested. Now, the pandemic as well reduced our margin for action, our ability to maneuver, and made things worse. First evaluation of these first 2 years is that overall health institution over about 55% have fulfilled their obligations. At the same time, we try to implement a special program on tuberculosis and to optimize it. We have specialized health organizations in this area. And since 2006, tuberculosis is also part of the financing of the fund. And here we also had to concentrate some efforts to introduce new methods, these new financing mechanisms to train staff and adapt the organizations. And when we made an analysis of our efforts in this area, we've seen that about 50% of the suffering from tuberculosis were patients who didn't have tuberculosis. And so we had a testing system put in place in the country. We put in place a mechanism where we promote primary health care first and foremost. So this pilot project has been going on for about 3 years and the results seem good. The costs, and we've seen a reduction of a twofold in the cost of treating tuberculosis patients. This not only improves overall medical coverages in medical institutions, but other areas as well. Unfortunately, since we don't always receive contributions, there's sometimes some problems with social payouts. So a great many of our funds are in the social fund for various reasons. And some areas were not sufficiently financed. Within the framework of our last form of state financing, the budget of the UMSN, we are no longer in the Republic or the public's budget, but we have our own budget. We're not a line in the state budget anymore. We have our own. And this is being regulated by various laws. And what is the result of this? Out of the 2015 visit, the social fund, and now we're getting almost all of the funds that we were promised. Next slide, please, on health insurance. Now, there are certain categories of the population that receive obligatory health insurance. The state decided that pensioners, children up to 16, people were on the dole, military, emergency care workers, and students are also covered by the state. So all of these people are covered by the states, and the funds for this will come out of the state budget. But in 2001, the contributions were established, and it was $2. So $2 a year the state provided to these categories. So over these 20 years, the state has not changed the level of contributions or payouts, and unfortunately, nothing has increased. In addition to these categories, there are workers. Then here the employers pay 2% to the fund. The workers themselves don't pay anything themselves. This is a 2% tariff, and this comes back to 98 and hasn't changed. Despite our multiple efforts to make amendments, unfortunately, this has not gone through the government or the parliament. Farmers, people involved in agriculture, they also pay, but this time 1%. Citizens that are not insured, these are about 30% of the population. I'm talking about, that means a lot of the potential working workers are not insured. These are housewives and others. But here we've come up with a medical policy, a health insurance policy. So any individual who is not insured under the state problems can buy this policy, and it's about $20 per year. But any person can buy this policy and receive medical services for a year. So we have some pretty big packages. The basic services are paid by the state to all members of society from the state. So we have a basic package which covers annual medical visits from the family doctor and certain specialists, and some 11 basic types of analysis. So insured citizens are able to get all of these 11 basic analysis, and the people who have the special policy get a discount for them. All the basic services not paid for, but then they get a sort of an 11% on things like physical therapy and other outpatient services. Now, I'm just talking about the state organization, state system. I'm not talking about the private sector. Each and every citizen has access to our clinics and private consultations. Right now, about $70 is paid out by the state for these. To reduce these out-of-pocket payments, these informal payments to the citizen. And in 2001, we put in place a single payout system. And this works both for insured patients and not insured patients. Right now, it amounts to about $8. And the uninsured paid maybe $12, $9. And in addition, medicines are provided to uninsured individuals, and we've expanded this by about, and payouts by expanded payouts by about 10%. Uninsured individuals don't have access to discount medicines. And the discount represents about 50% of the cost of medicines. And most people can get medicines out of any pharmacy and receive a discount.
So if you take a look, you'll see this is the basis of our financial system. All contributions are being accumulated within the compulsory health insurance. Excuse me, dear panelists. I'm really sorry that I have to interrupt you, but it's just we don't have enough time. So we promise to provide all presentations. Maybe you can present us with a short summary and conclusion. So do you see my my very last slide? So we see the slide number 3, says Ainur. So you can probably restart your presentation.
Давайте я тогда просто сейчас продолжу. Я бы хотела сказать, что основной урок, который мы сейчас...
I would like to say that the main lesson that we're currently drawing for ourselves is that it is extremely important in any situation to create a program in an adequate manner so that our statements, our programs were linked to the financing that we provide. So I believe it is very important to collaborate with the Ministry of Finance so that the health financing can be a flexible system. Unfortunately, our finance system is quite conservative, quite heavy. So sometimes it's quite challenging when it comes to finance. And it took us a while to convince the Ministry of Finance to provide financing. So I believe that it is very important to never stop and to carry on doing your work. So that's my conclusions. Thank you very much. Thank you very much, Clara Oskambaeva. Every country has its path when it comes to development. So yet another part of our webinar. So we'll publish a very short report based on this webinar. So maybe there is an opportunity to conduct a small study or assessment in your country on the topic of health financing, or maybe to further publish the policy supported by the network. So please think about it and present us with your suggestions in Zoom about topics, about topics for collaboration. And I would like to ask all participants to visit p4h.world/en and register there. You can do it right after the event. And so let's start with our questions. We received a lot of questions. I'll show you. So very first question for everyone, From Joseph Kutsev. So a question is following. Are there any critical changes in the reforms of a modern financing of budgets? What are the main changes that took place over the last 10 years when it comes to effective services and purchase of services by insurers? Maybe Madam Bayranova can take the floor with this. So, and then we'll carry on and provide the floor to Ada. So we don't see you very well. We don't hear you very well. So it's a bit worse, says Ainur. It seems like you're far away. When you're a bit closer to the mic, it's better. Thank you very much for this question. So this is the first year when we started introducing the insurance, so strategic procurement is being introduced together with the medical organizations. And now it seems that you cannot hear me, says the participant. We hear you well. Please proceed. So we gather analytical data to carry out assessment demand of the general system. And then we'll try to introduce the strategic procurement schemes. Now we've laid a foundation. When it comes to our achievements in IT, I can say that a lot has been done during the pandemic because everyone switched to the online mode. A lot of services were digitalized. All data of patients is digital. We don't use paper any longer. When it comes to monitoring of medical organizations, in this sense, we also apply digital technologies. So monitoring is being conducted online as well. Thank you. So the director of the Agency for Mandatory Health Insurance of Kazakhstan, Ms. Jaturanova.
She's from Ministry of Health.
Madam Janturanova, can you please raise your hand? And like that, we'll be able to give you the floor. Could you please press this button, raise your hand button? So I will read out the answers of this speaker. So she provided a written submission. So Kazakhstan uses budget procedures. Kazakhstan introduced effectiveness assessment system. So indicators of efficiency and quality are being used when it comes to procurements. So Ministry of Health also informs us that procurement of services is being automated. It's 70%. The IT systems are also being used. The payment mechanism is automated through IT systems. It's 90% rate. The question, the solution was found through changes in funding, but there are issues when it comes to the administration of two package of services. The first one is mandatory, and the second package is for insured persons. Since January, a proposal sounded to consider the issue of decentralization of the budget. So I apologize for not being able to provide the floor to this participant, but we received the written submissions. So, Madam Oskumbaeva, Kyrgyzstan. Good afternoon. I will probably disappoint you a little bit when I say that in general, 10 years ago, we tried to to define the volume of services when we worked with each and every organization. So far, we haven't moved forward. Over the last years, we've tried to improve our IT system, and I think this will be able to contribute towards enhancing our work in this area. Thank you so much. The next question, please, for Azerbaijan.
This is also from Joseph Kutsina. The financing from the state budget is in line with the global trend that tries to make a difference between the status of working status and the coverage. And then also a question about tuberculosis. Was this a way to a way of not fragmenting the system? There were in certain services some resistance to the verticalization of the tuberculosis and HIV care. And the idea was that they wanted particular financing. Many thanks, Joseph Kunze, for that question. We had some problems with the Minister of Finance who resisted, who wanted only to finance the people, citizens that were paying into the system over. Since the introduction of the system over the years, put in place a budget program. We were able to get additional financing. Obviously, if we included this into the insurance package, we had to change the legislation, increase the contributions paid by the state and so forth. None of this would be easy to do. So the insurance fund is better to have individual budget assignations for these particular areas. Many thanks. The next question was also to Azerbaijan. 2 questions, I believe. Free medicine available in your insurance package? And also from Mr. Bayanova. And what do you mean by bringing together small organizations into one? All right. Currently, we only provide free medicines in outpatient clinics. Unfortunately, the medical insurance doesn't cover all medical medicines currently, but we have included some medicines that are provided within our benefit package. And the medicines are distributed by the OMS systems. As for the bringing together, pooling of small organizations into larger ones, well, in our country, the country is divided up into regions, and there were a few regions, for example, the central hospital of the region, and then there was, say, a specialized section and a specialized hospital in another area. We tried to bring them together. Why? So that it would be easier to finance them, and also that the stream of the population went to the same place in the region. Before, there was a certain level of fragmentation. Each doctor worked in this or that clinic. He worked with his or her patients. So the idea was to pool these small organizations, small clinics, into a bigger one, so that citizens would go to one hospital, and from that place that they could go to other specialized organizations if necessary. Some of the issues of management, some management issues were also simplified by doing this. There's only one accounting office, there's just one director, and so on and so forth. There's only one HR director and so forth. Thank you. I think optimization also occurred in other countries. Let's move on to another question. This is for Kazakhstan. Turganovich Turganet headed up the fund of insurance for a few years. Let's say he worked in a critical period when it became nationalized. And the question is up on the screen. And thank you for your questions, sir. In 1996, there was an attempt to introduce this system, and we know perfectly why it wasn't successful. The second attempt, this time was successful, was at the national level in January in the 2000s, and Kazakhstan is coordinating this so that these similar problems that occurred in 1996, 1998. Please raise your hand, sir, and then you could answer the question. So we're waiting. Were you able to raise your hand? But just there's a little button on the bottom in order to raise your hand. Go ahead and push it. Good afternoon, participants to this webinar. I welcome everyone. I'm quite happy to answer this question. This is an important question. In the 1990s was the transitional period in terms of the budgeting for health services in our country. Spending for health, each region received funds, and starting from 2005, we tried to centralize the entire system, and 2015 we'll be able to completely centralize budgetary funds for medical services in the Minister of Health. Well, this covered about 11 million people, children, pregnant women, pensioners, and so forth. And the Minister of Finance provides funding for them. These are transfers in reality from the Minister of Finance to the Minister of Health. And then the Ministry of Health sends the funds out to the various medical institutions, the fund itself. Sends it to the funds, and then the fund sends out the resources to various institutions. Many thanks, Bulat Turganich. Another question for Kazakhstan, and Gurjan Shepebekova will answer it, who was not able to turn on the sound. I didn't know about this early enough. Are there problems with patients and their expectations on services? How is the state or the system dealing with the expectations and perhaps delays in payouts? Distinguished colleagues, good afternoon. Welcome to this meeting. Yes, we had some serious problems, and indeed they are still ongoing today to a certain degree, but certain measures were taken to reduce delays in receiving services. For example, we carried out monitoring to identify the defects in terms of consultations and diagnostics. And so we've set up a standard. It's about 10 days. So we're trying to ensure that people are able to get medical services within a period of 10 days. So what sort of mechanisms are we having in our country? We increased the number of people, of medical personnel providing these services. This included the private sector. In 2016, the private sector was only about 20–30%. Now they represent about half today. We increased or expanded the number of outpatient placements that were able to provide the services. We set out requirements so that they could also provide assistance. I'm talking about clinics. An important program is underway in regions to provide material and technical assistance for MRT, CRTs, and other high-tech medical services. We were able to increase the level and availability of equipment, but today in certain regions, or let's say in a zone of high risk, or because the delays are quite long. So this is still an open issue for us. As far as medical assistance, and this is inpatient clinics, inpatient hospitals. Sometimes the delays are up to 30 days before you can get into a hospital. So what are we doing? Well, we're trying to identify the most important services and increasing in that area. Many thanks for your answer. My apologies. I had to interrupt you. We didn't know there would be such an interest in so many questions on part of the participants. And really, we were supposed to stop this meeting 30 minutes ago. And so we'll just move on to certain questions to some of the speakers that were not able to answer yet, because there were also questions for the Kyrgyz Republic and others. Unfortunately, have to wrap up our meeting, perhaps at the most important, or when the topic is so hot. I would like to thank all those who participated, who really and took part, and thanks to their questions. And the Parliament of Kazakhstan is also participating and provided provided a very interesting question for Kyrgyzstan, but unfortunately we're not able to get to this question. Many thanks to Diallo, thanks to the debate show, Bezer Kharkhan, Mary Pierre, and the entire team. Many thanks to the organization for helping us to set up this meeting. We've heard about the main reforms in the 3 countries of the CIS, and I'm sure that we will be able to continue our cooperation via this platform that's called P4H. Right on the side at P4H, and we'll be happy to hear from you. Many thanks.